liver tumor. First is focal nodular hyperplasia, more common in female, more common in female. Etiology unclear. So on gross exam, you will see poorly encapsulated, there will be nodule, which will be poorly encapsulated. So in the center, sometimes they have a scar and sometimes large blood vessels. So you can have a scar, sometimes large blood vessel. And then fibrous tissue will be arising and radiate towards the periphery. So if you do the CT scan on this patient, you will see hypervascular mass which is vascularized. Arteriovenous connection can be there. But thing to remember is hypervascular mass. Focal nodular hyperplasia, tumor-like condition, common in female. And then the clues will be gross and CT imaging. So if you do the LFTs on these patients, let's say the mass is compressing the liver, hepatocyte, their AST, ALT will be high. And when you check the ALK phos in these patients, which indicate cholestasis or GGT, those will be normal. Cavernous hemangioma is the most common benign tumor of the liver. Usually between age of 30 to 50, diagnosis is made on CT scan. Biopsy is contraindicated. Why? Because it can bleed. You're not asked you commonly about these. Hepatic adenoma. Okay, this is the one they will ask you most commonly in the exam because this is so common. More common in female. It is associated with OCPs, oral contraceptive pills, and that will be the clue they will use in the question. So there will be a highly vascular tumor with tendency to rupture during pregnancy. Why? Because pregnancy will produce estrogen. Increased estrogen level will increase the size of this hepatic adenoma. Increased risk of rupture during pregnancy. Treatment based on size. Size less than 4 centimeter, leave it alone. More than 4 centimeter, causing symptoms, symptomatic, surgical intervention. Hepatic adenoma. On CT scan. Next is angiosarcoma. It's a malignant tumor of endothelial origin. The clue will be associated with exposure to arsenic and vinyl chloride. So both arsenic and vinyl chloride, they are also associated with hepatocellular carcinoma too. Liver is the most common site of metastasis too. And the way you will see metastasis, you will see multiple nodules in the liver. So different malignancy like GI, especially the colon cancer, and then breast cancer, lung cancer, can metastasize to the liver. So sometimes they will just give you this image, the CT image, and you'll be making your diagnosis. So the case will be that 35-year-old male presented to the, and I'm telling you, a lot of time we see this all the time in the hospitals. 35-year-old male uh, sent to the ED by PCP because patient was examined by PCP, and he was looking, his eyes were looking yellowish, and the only complaint patient had in the ER was fatigue. Otherwise, he's working, everything is fine, he has no other complaints. So you thought that, okay, maybe you should do the basic blood work and you check the liver. And when you check the liver, the AST and ALT is slightly elevated. So let's say the normal is less than 40, less than 35. In his kind of situation, let's say maybe it is around 150 and 140 AST, ALT. Patient on examination, everything is fine, and you did the CT scan of the abdomen, and CT is full of meds. You went back to the patient, you asked the patient, do you have any other complaint? And he said that, yeah, sometime he bled with stool, sometimes he has some bleeding with stool. And the next step, then you did colonoscopy, diagnosed with colon cancer. You will see these kind of patients. Or they can ask you that, okay, you saw this image, what is the most probable next step you will consider in this kind of patient? Let's say they'll give you the liver function test to AST, ALT is high, then I think the first step to start with is colonoscopy. Let's say if the colonoscopy option is there, I will definitely do CT scan of the abdomen. If this is diagnosed on ultrasound. So mets in the liver start with GI malignancy. Okay, the next is hepatocellular carcinoma or hepatoma is the most common primary liver cancer, usually around 5th to 6th decade of life. Most common risk: cirrhosis, hepatitis B, and hepatitis C virus increase the risk of hepatocellular carcinoma. Alcoholic cirrhosis, alpha-toxin, we already discussed, vinyl chloride, we discussed, hemochromatosis, Wilson disease, alpha-1 antitrypsin, primary biliary cirrhosis. So all causes of cirrhosis can lead to hepatocellular carcinoma. Pathogenesis associated with cirrhosis, hepatitis B, hepatitis C, they are the risk factor. This is hepatocellular carcinoma. So the gross finding will be, you can see focal or you can see multifocal too. Diffusely infiltrating cancer with or without pre-existing cirrhosis, with or without cirrhosis. So this cancer can invade the vessels. It can invade portal vein, hepatic vein. Microscopic finding: presence of bile containing neoplastic cells. They will not ask you about the microscopy in this kind of situation. So what are the clinical findings? These patients can present with abdominal pain, or they can have symptom of cirrhosis too, because let's say there is a huge mass in the liver that can cause portal hypertension too. And this portal hypertension is similar to portal hypertension in cirrhosis because this mass is compressing the whole liver. So it can either present with pain or symptoms of portal hypertension, which we already discussed in cirrhosis. So rapid enlargement of liver with cirrhosis, increase ascites with blood in the fluid. Okay, the clue is, so when these patients have mass in the liver, this mass is compressing the vessel, and these vessels can bleed. So when they produce ascites, this ascitic fluid will be full of blood. So bloody ascitic fluid is the clue for the diagnosis of hepatocellular carcinoma. So let's say if they give you ascitic tab finding, so you do paracentesis, and the paracentesis is full of RBCs or blood. Think about cancer. Lab finding alpha fetoprotein. So let's say if you see liver mass, the next step you will order is alpha fetoprotein level, because that is usually elevated in 70% of the cases of hepatocellular carcinoma. Their liver enzymes will be high, we discussed. So hepatocellular carcinoma, it can produce other hormones too. One is erythropoietin, so that will result in polycythemia. So these patients, when you do CBC, their RBCs will be very high. They can also produce insulin-like growth factor, which can cause hypoglycemia. But this is not very common. Insulin-like growth factor, uncommon, but erythropoietin we actually saw in the hospitals. So parathyroid hormone-related protein can be produced. Their calcium level can be very high. This is also common. So when you check the BMP on these patients, metabolic profile, their calcium will be in the malignant range. It's usually around or greater than 12. Normal is less than 10. So hepatocellular carcinoma can produce other hormone. Number one is erythropoietin. Number two is insulin-like growth factor, can cause hypoglycemia. Third is parathyroid hormone related peptide, can cause hypercalcemia. How to make a diagnosis? You can do CT scan, you can do ultrasound to localize hepatocellular carcinoma, you can do dedicated MRI. Angiography is not usually required. Treatment. So once you have the mass in the liver, the next step you have to do the biopsy, which will give you the absolute diagnosis. Treatment is, if the mass is solitary, then surgical, otherwise chemo, and then liver transplant is one of the option depending on different factors. If unresectable, mostly die, and I would not say that mostly die, because we have so many treatments available these days, and you'll see these patients for years because there are so many options available. It depends on the stage too. So no one will ask you about the prognosis.